stay also for many, many years if we have. So now we think about things like also mentioned, the receptive surgery access plan can be, or regeneration. So today I would like to touch this topic, regeneration. And here, actually, when you look to the literature, is almost no evidence. All these studies, they are very, very different, heterogenic, and there is no single technique, as what you have mentioned as well. So everything that comes to the topic of regeneration after periodontitis, it's all the time about this question: can we get the whole integration, implant disintegration? How to decontaminate, how to clean the surface that we can augment the bone. And perhaps on one device today, it's a electrolytic cleaning, which shows kind of promising results. And then when it was available on the market, we started a study. Here I'd like to present it. We had like 15 patients in control group and 16 in the test. And with our colleagues who were able to publish it, it's accepted by clinical implant dentists and really research. And here, everything was done in the same way. Initial conservative treatment, and then the surgical treatment was the same, just one difference was that in a test group we used electrolytic cleaning addition. So full thickness mat was elevated, all the spinal tissues were clean, also mechanical surface of the implant was clean. In a test group, additional electrolytic cleaning, and augmentation was performed in a vertical augmentation sequence. Right? Just remember it fixated on the palatal side. And also, what we did here, we still use this golden standard autogenous bone. And yes, as I mentioned, other materials show better results than systematic delivery. But when we talk about autogenous also not the same. So we use tuber bone from tuber. And everything was covered with the membrane and suture complete. So after 6 months, all cases were uncovered, and as you can see, yes, this case is extremely nice. It's very good quality and amount of the bone. For sure, we didn't get all cases like this. Just put it here as the most beautiful one, but you just can imagine what is possible, right? And usually when I get cases like this, I ask myself, okay, so what's the step with it? Why we were so successful in this situation? In total, we were able to augment 4.4 millimeter on average in this case. So still 2 millimeter of the bone loss plus evident on average in cases because of different factors. Maybe the implant was not without lateral stitching, without conical connection. So augmenting such cases normally, so we will not get the bone above usually. Or initially we see a bone grows above, but basically given the body we have this 1-2 millimeter of bone loss later. We have no lateral stitching and no conical connection. So before and after also additional illustrations just to show the possibilities of the bone regeneration after periodontitis in extreme cases. And yes, maybe to discuss in scientific way, do we have here also regeneration? We cannot say that we have to make take a drapandil and take it out and make it histology. But all the clinical view what you see after opening the flap, even in extreme cases, and what you receive in X-ray, on X-ray, and what you receive clinically on function. So we have really very, very beautiful results. So to discuss this issue, so why it looks so nice, we have several explanations. But the first thing, again, coming back what I started with, non-surgical treatment is the most important thing. And here, I think, worldwide, we don't wait long enough after conservative treatment. So I would say here, just 50% of success of regenerative procedure will be how good we were with the conservative treatment. So we have to start to augment the bone only when there is no signs of inflammation. So if we take a scalpel and we just cut area where we have inflammation, then the healing will back. Perhaps also autonomous bone doesn't function so well because we have inflammation, right? So that's why we have to be rid out of inflammation. And this is very good illustration. So we have still here bone depth maybe 7 or 8 millimeters, but no pus, no extensive bleeding. Even the growth, it's also the soft tissues looks healthy. We have like a perineal bias, but it's not like inflammation. So very interesting here in this situation. The second, of course, if we compare the generative potential like with small defects and other cases when we have like very extensive defects, so of course here we will have really bad results. And when we put everything together, so the results are mixed. So, just half of cases we were able to augment. When we have bone leaves, right, the thinking of myself should be like the same like you do a vertical bone augmentation. We have bone leaves and recipient area, so where we can do bone augmentation in a regular way, not in a back speed. So this is possible. But if we have like a situation like this, when we have no bone adjacent to the defect is huge, it's large. So for sure, soft tissues are already there. So to do something here is almost impossible, for sure. So it's not a case for regeneration. The third thing, surface decontamination. So this is always the most important part, perhaps. Yes, this is an interesting thing. I think more and more studies are coming just showing, is it possible, really, is it possibility to have a complete disinfection of the surface? This electrolytic approach shows that it's possible to clean almost 100% the surface, even if it was infected. And animal studies, in vitro studies as well, showing really very nice results after cleaning. Plus, additionally, after this electrolytic cleaning, what happens with titanium surface, it becomes hydrophilic. And absorption of blood, it looks like a kind of SLA active phenomenon, right? And when we look to publications and trials where the comparison of hydrophilic and hydrophobic surfaces for bone augmentation doesn't matter, xenograph or allograft, in both scenarios, hydrophilic surface shows much better results. Again, this one small thing maybe also has additional impact to the final result. And finally, autologous bone from tuber. This is what we do regularly, like a standard treatment in aesthetic area when we have no buccal wall. So IVR technique, immediate dental reconstruction using a bone and soft tissue graft from tubers. And this was described by Doctor-Meliva from Brazil. Something very exceptional we have in the tuber area. And as some publications show it also, that it's kind of depot of osteoprogenitor cells, right? Because with no other technique, I have seen such a good re-establishment of a buccal wall with immediate implant placement, with immediate horizonalization, having no bone initially, and after some time, I think 2, 3, 4 millimeters of buccal wall in the aesthetic area. So that's why we just decided to use it in peritonitis augmentation cases as well, just to collect it, to position around the defect without any fixation, just collagen membrane as a holding space, just as a holding all these chips collected from tuber around the defect. And finally, the approach